The diagnosis came before the launch of the first edition of the TV show Kaun Banega Crorepati, the Indian version of Who Wants to Be a Millionaire. Wealth or caste cannot protect anyone from the miseries that are inflicted upon the inner cities. Tuberculosis is no longer a disease only of the poor or an abstract threat from history. In India, where the rich and the poor live less than a sneeze away, their destinies hopelessly intermingled, it is the daily business of life.
Welcome to Dialogues. I'm Garry Aslanyan. This is a special series of the Global Health Matters podcast. In this series, I'll be blowing open some of the echo chambers that exist in global health. To help me in this quest, I've invited thoughtful and inquisitive individuals from different walks of life. Each of them has explored and written about global health issues from different disciplinary perspectives. I hope this dialogue series will give you, the listeners, an opportunity and space to step out of your daily routine and contemplate global health issues through a different lens. So let's get started. For our second Dialogues episode, I'm joined by Vidya Krishnan. Vidya is a health journalist and author based in Goa, India. Vidya invested a significant amount of her writing career investigating and documenting the impact of tuberculosis on Indians of all walks of life. In her book, The Phantom Plague: How Tuberculosis Shaped History, she weaves together a multitude of narratives over time, starting in 19th century New York to modern-day Mumbai. She explores questions about the interplay of race and caste in policies that influence the spread and control of tuberculosis in our day and age. Hi Vidya, how are you?
Very well, Gary. Thank you for having me.
Where do I find you today, Vidya?
I'm in Goa. I'm in Goa, in India.
Great. Welcome to the show. Vidya, I wanted to start by asking what really motivated you and inspired you as a journalist to investigate interlinkages of science and society.
I grew up in Bhopal, which is a city in central India, and I grew up right after Bhopal was the center of the world's largest industrial disaster in 1984, when a pesticide factory leaked an intermediary substance, and it poisoned and killed half the city from cyanide poisoning. And there was a long court battle. At the end of it, no one apologized and no one was held accountable, and no one actually was really rehabilitated. And everything about my journalism I have learned is from that one single epic story, which includes law and justice and politics and advocacy, and all playing out in a small town. And that was the backdrop against what I grew up, and everything I write about, which is I don't think it's about science or medical history or race or politics. It's actually about the interplay of these things. And I believe the only place these things tangibly come together is in literature, where as a writer, I simply just have to believe that nothing can beat a good story.
Vidya, I'm curious, is tuberculosis only a professional interest, or you've had a more personal encounter with the disease?
I mean, if you mean that if I or someone in my life has had tuberculosis, no, not my immediate family. But is this personal? Yeah, yeah. You don't spend 8 years on a story without it getting personal. And I also live in a country. I mean, one is while I was reporting on this book, I've lost a lot of friends to this disease. But I also live in a country where there is so much of tuberculosis, and yet somehow people are just blind to it. And this book, when I started writing the book, it wasn't commissioned. I didn't have a publisher. I simply had to write because I saw so much of it. And I was working for a newspaper at that point, and it just doesn't do justice after a while to write 300, 600 word stories about something this huge in scale. And at some point I just realized I was essentially colonized by these stories. And I tried to not write this book for a long time, but then I could not stop thinking about it. And I do believe that stories cull writers out of people, and that's what happened with me.
Interesting. And you take readers in your book through a trip or a journey which starts in the past, and you highlight how history has shaped TB and tuberculosis. Why did you feel the historical perspective is valuable, and how could it challenge our understanding and inform our actions in combating TB today?
I personally think historical perspective is always valuable, but it's particularly valuable when we are going through these mega events like plagues and famines and wars, because people tend to search, very desperately for answers to make sense of things that can't be made sense of, essentially. I spent a lot of time reading history at that point, and I'd say all of it benefited from my reading of history, all of my reporting, because essentially we as societies and human beings are just predictable creatures. And about how can history help in combating TB? TB was and has gone back to being the number one infectious disease killer. And every plague before this one has taught us the same thing, that no one will be safe until every last one of us is. I feel like a stuck record saying this over and over again everywhere I speak. But it was quite surreal to see the science denialism and the racism and uh, casteism in my country. All of it that I had read about, the xenophobia, all of it just came to life in the past 3 years. If we don't act collectively, because infectious diseases, more than anything else, it's about collective destiny. If we are greedy and if we think in these myopic ways, I don't see any way we will prevail over these pathogens despite all the fruits of modern medicine.
Interesting you mentioned that, because in this season we've recorded a couple of specific History Matters episodes, and our audience really loved those episodes. So important to know history, as you say. It was really interesting for me to learn from the book about the influence of the housing policies in Mumbai on the spread of tuberculosis. Let's hear more about this from your book.
That aerial shot of the slum clusters is now known as the trigger photo within DFY. It was the first time the DFI staff could visualize the scale of the health crisis. The photograph resembles a densely stacked honeycomb. There are 59 rooftops, tiny squares, and red arrows coming out of them. Against each arrow, DFI researchers have put a number to reflect how many TB patients live in each building. The markings get denser, more clustered on the lower floors. One building in particular stands out, building number 10 of the NP compound. Researchers had found 51 drug resistant TB patients in one building in one of Mumbai's sprawling ghettos, an exceptional find even for a country like India. It was the equivalent of finding 51 people suffering from a rare cancer, all neighbors. At least one member of every family living inside building number 10 had drug resistance responding to the antibiotics. Poverty is the disease, TB is the symptom. The global fight against TB will be won, or more likely lost, in India because a century of bad housing policy decisions has meant that Mumbai's rich residents live in their gated luxury archipelago of enclaves, high in the sky, while keeping the poor residents of Mumbai in serving distance as their cooks and drivers and security guards and lift operators. Together, but separated more than ever. For the bacteria, this is a great opportunity to thrive.
What do you think is the learning from the experience in Mumbai that could benefit other cities to not make the same mistake?
Thank you for that question. What's happening in Mumbai today was happening in New York in the 20th century. The Industrial Revolution led to the 7 cents housing, which led which made the city, the ghettos a petri dish for tuberculosis, and globalization simply outsourced these dirty jobs to dingy places far away to essentially countries like mine. So why Mumbai is where we see this happening is Mumbai is the financial engine of India. But what's happening in Mumbai is just a microcosm of what's happening in every big mega city of the world. We are connected. Every part of the world is connected to every other corner with airports. And we all have to deal with this question. Are the poor who live amongst us, especially in big cities, the refugees, the workers who migrate from smaller towns to bigger ones, are they meant to live in subhuman condition? And what does it mean for the society collectively if you force a certain section of your society to live in these subpar conditions? When I was reporting in Mumbai, I met this doctor who was the medical superintendent of Suri Hospital, which he jokes that if tuberculosis was a religion, Suri would be Mecca. It's it's the largest tuberculosis hospital in Asia, and I now know from living in Mumbai. While reporting the book, I lived there, and I lived in a posh neighborhood in Mumbai. But I'll head out to the ghettos, report, and come back to my safe distance. But then this is increasingly more and more fragile. And what the housing crisis in Mumbai teaches me essentially is this is not a coincidence. All of this is willful neglect. We live in congested cities, but we are so segregated by race and caste and class, and pathogens don't respect these boundaries, and we just have to stop thinking. If we are to combat them, we have to change how we think about them as well. And a lot will begin with making sure that we have better housing for poor people. But unfortunately, in my country, we have a situation where Bollywood romanticizes this living in slums. And we live in a society that's just blind to the pain that's just inflicted in different neighborhoods.
Bollywood romanticizes living in slums. This is the first time I've ever heard of
Well,
this. How does that happen?
Slumdog Millionaire, which won the Oscar,
Right.
was very famously based in the largest in Dharavi, which is the biggest slum in
Uh huh.
Asia.
Uh huh.
And also, we have in Bombay, if you're a tourist, they take you on a Dharavi tour. Like as a tourist, you can just go how and see
See,
how
yeah.
poor people live, and everything about it is just so ugly and exploitative, and so blind to the living conditions.
Hmm. Vidya, interwoven in your book are the stories of several patients who you have encountered, and you mentioned how you visited and talked to them. Why, in your opinion, is so paramount to anchor our efforts to eliminate tuberculosis within these stories?
Again, thank you for that question. I think one of the reasons why this book has done well is because I'm not a student of medicine. So I did not approach this biography of a bacteria from a medical point of view. So I did not see these people as patients. I saw them as people, with dreams and families and mortgages and dogs, and who just got caught in this very ugly turn of events in which they just have no control. And why is it paramount? I mean, when you see the patient and not the person, what is implicit in that, and I see a lot of that happening in India, is that you see the person as a disease carrier. And I was in the US when the Trump administration was in charge. And with infectious diseases, if you don't see the patients as people, that's the slippery slope we get to. And I actually believe in seeing past this infection and looking at the person's life is important, because more than anything else, it requires compassion. And I believe compassion is an absolute necessity in global health. And it's also the most missing component in our TB policy. And I don't mean compassion as an indulgence or as a moral stand. I literally mean it as an urgent need to look at a policy that is, that addresses infectious diseases, especially in developing nations. Because if we don't very carefully incorporate compassion into policy, we end up with something like DOTS. DOTS was just from the very beginning unkind to patients. It was, to expect a patient to turn up at a DOTS clinic day after day after day, even if they get fired from their jobs, then they get visibly, if you're standing in front of the building, you are visibly a TB patient, so you get ostracized. And this lack of thought, essentially, of course, it's at a philosophical and profound level, great to be compassionate, but the way I see it, it makes the policies inefficient. Is the biggest proof that the DOTS policy failed.
Hmm. So, another fascinating observation you made in your book is the tension between accessibility of antibiotics and also the inequity that can arise if access is limited. Could you tell us more about this situation in India?
I think, Gary, tension is a very charitable word. I would not use the word tension here. It's just so morally fraught to deny someone medicine for someone in the future. And there is just no way you can say this without answering the question. Every time I've met an Indian doctor who says this to me, I've asked them, give me a visual of what does the patient in the future look like. Is it a rich, upper caste, Hindu, Brahmin, man or woman in my country, but essentially at a global scale? Why we want to save antibiotics is when drug-resistant tuberculosis reaches Seattle and Geneva and places like those, and you want to save the medicine for rich white people or upper caste Hindus in my country, and it's there is just no way that we can talk about this without addressing the fact that in every system, the rich will get the treatment. It's the poor, it's the lower caste people or people belonging to different races who will be left behind. And I personally find that abominable.
And Vidya, what do you think should be done about this?
I mean, almost immediately for TB, I will say that we just simply have to not enforce patent monopolies. It's a global health emergency of a scale. Everything that happened in COVID has been happening for decades with TB.
Hmm.
In India, the entire TB program got COVIDized down to the helpline of the ministry, and infectious respiratory diseases don't simply go away. So the first thing we need to do is look at how technology is transferred, because vaccines and drugs, first and foremost,
Mm.
it's technology, it's somebody's intellectual property. And I feel like TB elimination will not be achieved if the medicines, the latest, most humane therapy is locked in a patent monopoly. And again, the most frustrating part of this is that all of the new therapies in tuberculosis actually came out of a genuine public collaboration. Universities put in money, philanthropies put in money. A bunch of the late stage clinical trials on bedaquiline were done in India and South Africa. So patients also pitched in. And it's really
Right.
unfair that you use patients for research, but then when it's time to, and all of these drugs came out of industrial scale subsidies to pharmaceutical companies, and now they're in patent monopoly. So that's the most urgent thing, I'd say.
Vidya, you make a statement there is no public in public health any longer. Could you expand on this statement?
Yeah. I genuinely believe there's no public in public health. There is little health either. There is a lot of cash. Yesterday, I was at a conference where I learned that during the pandemic, in India, there's this reputation that there are a lot of tech billionaires in India.
Mm.
But because of the pandemic, we now have more pharma billionaires than tech billionaires. We minted out a new billionaire every 9.5 days during the pandemic. And we this is not just true for India, but of course it's true for India. It's true for the rest of the world as well. If there was public in public health, there is just no way that vaccines that have been brought to market with heavy investments from publicly funded universities and taxpayers will just be handed to pharmaceutical companies just for a song. We let millions of people die from a preventable vaccine curable disease. And that really should make us question everything about this structure that we are trying to defend. It's a very cruel thing to have medicines and not share it. And I don't know how to explain it other than, just say that there is neither public nor health in it, just profits.
You wrote your book before the actual pandemic, and yet, as we just talked about, we saw history repeated itself in some of the aspects. What are the two lessons from your exploration, if taken on board, could change the outcome of future pandemic?
I know we are negotiating a pandemic treaty now, which also looks the dice just seems loaded against uh, post-colonial, very fragile nations. And the two lessons that the first and the most obvious one is that we have to decenter manufacturing because our supply chains are just too broken. Every continent should be able to manufacture for itself and supply itself. And intellectual property cannot be a hurdle for it. The pandemic was a perfect time for countries to issue compulsory licenses, like the U.S. government did for anthrax soon after the anthrax attacks after 9/11. So rich countries actually do get to use the flexibilities in the law. It's the poor nations, it's the post-colonial nations that are not allowed to. And the second lesson, this is my personal pet peeve about, I don't understand why we think we can fund global health through philanthropy. We cannot. We simply just cannot. It's not a coincidence that a global health order, which is entirely managed by very few foundations to fund it, then we result in global emergencies. Then we look at billionaires for solutions because we've not created systems in peacetime. So in wartime, we look at saviors to come and save us. And also the thing about casting yourself as a savior is you are expected to do some saving when a crisis hits. Organized philanthropists are also equally responsible for getting us in this position because they have poured in so much money over the years in states like Uttar Pradesh in India, where during the second wave, bodies were floating in our rivers because people had by then run out of space in the graveyards, and they were just Hindus were pushing bodies in Ganges, which is our mythical river, which Hindus believe will give you nirvana, eternal salvation. So if you can't give them a pyre at the end, you push these bodies in the mythical rivers. And that's why I say in India we had a 14th century plague. Sure, the government is responsible. in every country where organized philanthropy is a pillar to make healthcare possible. It's not feasible. It's very dangerous.
So just I'm clear. What was the second lesson,
The second
Vidya?
lesson simply was to fund our own health as a taxpayer funded, no philanthropic involvement in it. It's just my business with my government.
I understand. Vidya, in our search for book authors from low and middle income countries, we have not found many. Why do you think it's so important for journalists or writers like yourself to share the stories of their own people, like you have done in this book?
I'm a writer, so I'm biased towards stories. I feel like every story is important to give us a comprehensive picture of this mosaic that we take as a global health order, which actually is very overrepresented from very limited parts of the world. Why it's important for every story to be recorded, but more than every story, the stories of the lowest common denominators. It's important. Again, I'm a writer. I believe on having a granular information from all perspectives actually is important to make us compassionate. For make room for each other's stories.
Mm-hmm. Thank you. Finally, TB still remains with us, and there is still a lot of work to be done with tuberculosis. But where you've seen any pockets of hope and promise of progress, Vidya?
Yes, I actually do remain very optimistic at this point. One of the sheer, sparkles in this process is the patient networks that have come together, and the advocacy with, they have led from the front. Two patients, Nandita Venkateshan and Fumeza from South Africa, challenged successfully Johnson and Johnson's patent on bedaquiline, and it's so heartwarming to see these kind of changes. People finding each other, learning each other's story, finding strength in each other's stories. And the other silver lining because of the pandemic is there is now more conversation about infectious diseases, uh, more than I've seen in the 7-8 years I was reporting on this book before the pandemic. And most of all, there is in countries like India, there has been significant expansion of molecular testing. Um, all of this actually gives us a strong network to build on, to end, or to at least try to meet the targets we've set ourselves to eliminate TB. I do
Hmm.
believe we have all the tools to do it. It's just a question of whether we are going to prioritize doing what the right thing is to do.
Thank you, Vidya, for joining me today and sharing your reflections and your work. It was a great conversation.
Thank you. It was really nice to meet you.
Vidya explores tuberculosis through a societal lens as an Indian living in one of the countries with the highest incidence of tuberculosis in the world. I take away from my conversation with Vidya a new appreciation for a complex range of factors that influence this disease, something we all think we know, but we don't always account for when thinking of how to tackle this age old public health issue. From housing policies to decisions on patent rights, achieving progress in combating tuberculosis is no easy task. Vidya's conversation also reminds us of the ongoing colonial remnants and commercial interests that have a direct influence on the achievement of health equity. A positive development from early this year is the adoption of a historic declaration by member states at the 78th United Nations General Assembly. The declaration gives momentum to ending tuberculosis by 2030 and providing life-saving treatment to 45 million people. Let's hear from one of our listeners.
Thanks to Garry and the TDR for producing excellent podcasts. I have liked in particularly the last one about the stigma, the fear, and the inequalities and the lack of knowledge that relates to Chagas disease. And your talk with Daisy Hernandez. This is a very good way of bringing humanities to global health. I wanted to also call my attention for a podcast about climate change and health that promotes health arguments for climate action and the health co-benefits of mitigation, because we need to ensure that there is evidence for a health-centered response to climate change in order to mobilize resources and financing for action.
Thank you, Maria Teresa, for your recommendation and for listening to the dialogue. In Season 1, we had an episode on climate change, but I agree, there is so much more we can discuss. To learn more about our dialogue series and the content of this episode, visit the episode webpage where you will find additional readings, show notes, and translations. Don't forget to get in touch with us via social media, email, or by sharing a voice message with your reflections on this episode.
Global Health Matters is produced by TDR, a research program based at the World Health Organization. Garry Aslanyan is the host and the executive producer. Lindy Van Nieker and Obadiah George are content and technical producers. Priya Joy is the curator of the dialogue series. The podcast editing, communication, dissemination, web and social media designs are made possible through the work of Maki Kitamura, Chris Coase, Elisabetta Dessy, Isabella Suder-Dayao, and Chembe Collaborative. The goal of Global Health Matters is to produce a forum for sharing perspectives on key issues affecting global health. Send us your comments and suggestions by email or voice message to tdrpod@who.int and be sure to download and subscribe wherever you get your podcasts. Thank you for listening.